Okay, hello and welcome everyone. Thank you all for attending today. My name is Alex. I am a lupus warrior of 15 plus years. I am a volunteer for Lupus Ontario, as well as a facilitator for the men's support group. With that being said, let's get into what this webinar is all about. So this session will delve into understanding the connections among diet, inflammation, and immune system function, with special attention to SLE by Dr. Derek Holland. He will examine how these conditions intersect and affect patient health and treatment strategies. Additionally, he will offer practical nutritional approaches to managing SLE, discussing evidence-based strategies to reduce inflammation and improve disease outcomes through diet. Dr. Holland was born in Sudbury, Sudbury, Ontario. He attended University of Guelph, where he did his Bachelor of Science in Biomedical Sciences and his Master's in Nutritional Science. He then went on to earn his MD at Dalhousie University and completed his residency training in internal medicine at McMaster University, followed by a combined fellowship in allergy and immunology and rheumatology, and then the Jeff Carr Lupus Fellowship. He now resides in beautiful Shanty Bay with his wife and 3 sons, and recently moved his practice from Barrie to Orillia. He is an associate clinical professor at McMaster University and assistant professor at the Northern Ontario School of Medicine in Sudbury. Before we begin, just a couple of housekeeping rules. The chat is available and will be monitored throughout the whole webinar. We do encourage questions, so if you have any, please put them in the Q&A function, and I will read them aloud at the end for our little Q&A session. And lastly, we ask that you refrain from taking any screenshots. Everything is being recorded and will be posted online. So without further ado, I will go ahead and pass it over to Dr. Holland.
Okay, awesome. Thanks, Alex. So I saw 52 participants, so I'm used to doing like Zoom calls where you can see folks and know that everyone's out there, but I'm trusting you guys are all out there, 52 folks and our team here. So we're going to have I'm going to try to get through my slides in about 40 minutes and leave. What time does it go till, Alex?
Can you hear me?
Yeah, I can hear you.
I think it was 1 hour with 15-minute Q&A.
Okay.
Correct me if I'm wrong, Lisa.
Perfect. So as Alex said, we're here in Orillia, and it's a pleasure to speak with you this evening. I really got interested in lupus, like even before medical school. I got interested in autoimmune disease and inflammatory disease before we really had the concept of autoinflammatory disease. And what was fascinating to me about lupus and other autoimmune diseases was a couple of things. Like one being that, okay, these are things that people aren't born with, that are acquired. And so the thinking was sort of like, well, if these things are acquired and they weren't there before, maybe they can be not there in the future. And also, lupus, like a lot of immune diseases, being marked by periods of flare and remission. I thought, okay, this is like really interesting because these conditions can flare and remit in a given individual. So like every given individual holds their own information about, what could help them to be well and what might make them unwell. So, and I think that, that sort of vantage, especially the second part of it, really I think still applies tonight. And we've already got stuff in the chat here. Alex, are you looking at our chat?
Someone will be monitoring the chat the whole time.
Okay, so just interrupt me if there's something in the chat. We can do questions as we go too, or any, you know, if people are having troubles hearing or something like that. So just pipe up in the chat, and I'll trust whoever's watching the chat is going to interrupt me as we go.
Sounds good.
Okay, so here are my disclosures related to tonight's talk. Okay, number one, vegetables aren't my favorite, but I'm increasingly interested and curious. And whoever can post the author of this quote in the chat first wins the honor of having been the first to post the author of this quote in the chat. Okay, are you ready? However, I'm just mad about Saffron, and Saffron's mad about me. Okay, that's your quiz. That's the interactional part of the talk, unless you post, you know, comments or questions. Okay, the second disclosure, I have a master's in nutritional sciences. However, that was mostly filler while I was trying to find someone who would let me into medical school. But I will tell you that, you know, I started from a kind of very holistic place at the good old Granola, University of Guelph, for any alumni among us here tonight. And I actually thought about being a naturopath, and my mom and stepdad said, Derek, why don't you be a medical doctor? You can, you know, bill the government, order lab tests, order drugs, and you can still do all the things a naturopath does. And that was like probably like some of the absolute best advice of my life. And other than that, I have really no disclosures relevant to this talk. I did eat some vegetables just before coming online, though, I will tell you that. Okay, so the way we're going to do this talk is we're going to kind of have a little intro bit. I'm going to zoom in on lupus, and then I'm going to zoom back out. So, and this is my first time doing this particular talk. I did a talk for the McMaster rheumatology group a couple years back, but this is on the anti-inflammatory diet. But this is the first time for this talk. So, you know, grateful for any feedback, and it kind of meanders a bit, but I tried to make it as much of a linear exercise as I could. Okay, here's good old Hippocrates, who is considered the father of modern Western medicine. And being the father of modern Western medicine, I think it's really cool that we can kind of like take a big circle back to the man himself, Hippocrates, and go, you know what, this guy really was where it's at. And I think what he says here holds true. He said, let thy food be thy medicine, and medicine be thy food. And then, you know, a couple thousand years later, this guy Paracelsus, who looks a little nervous. I don't know why he's looking so nervous. I think he might have borrowed his wife's hat. I'm not sure. But I guess this was the best portrait they could get of Paracelsus, looking a little skeptical. But he says, all things are poisons, for there is nothing without poisonous qualities. It is only the dose which makes a thing poison. Swiss physician and alchemists. Of course, alchemists were people who, you know, wasted a lot of time trying to turn lead into gold. I don't know how much time he spent being a physician and how much being an alchemist, but he was both. And by the way, you know, Hippocrates lived to be 90 years old, man, like 2,500 years ago. That's pretty cool. And I don't know what happened to poor Paracelsus at the age of 48. I don't know. I need to learn more about him. But that's a beautiful, you know, quote. And you sort of take these two ideas together, and we could say, thus, every food is both a medicine and a poison. And Paracelsus also said, you know, it's only the dose. It's only the dose that defines what's a medicine and what's a poison. And you know, and this goes like for every single thing, including, say, water. You know, even water is a poison. If you drink enough water, your body cannot concentrate your sodium and electrolytes sufficiently, and even water can be fatal. Or as Gordon Downey, and by the way, Erica Lynn Thompson made this, like, put these slides together, and she's got a knack. She told me that purple is the color of lupus. I didn't know that. I should have known that. But I did remember this image of Gord Downie wearing a purple hat. And, on his final tour, I saw him wearing that hat. And so it kind of fits nicely. Might be the prettiest slide we have here. So, Gordon Downie said, either it'll move you or it'll move right through you fully, completely. And I love that quote because what it means is, everything has an impact unless it doesn't move you at all. Like say neutrinos that are going through us at trillions every second. But anything that impacts your physiology impacts your physiology. So, we are what we eat. Everything we do, not to become ultra neurotic, but everything that we encounter in life has an impact on us, unless it doesn't at all. So now we're going to zoom in on this nice paper published in 2022 called, see, now I'm curious to look at this chat. Who's our chat person? Is there anything we want to pop like into the conversation here from the chat right now?
I'm monitoring that and nothing of concern right now.
Nothing burning. Okay, okay, good, Alex. Good to know that you're watching it and you'll pop in if there's something timely for us.
Just
Okay.
that Mellow Yellow by Donovan was
yes. Yes, thank you. And saffron happens to be an anti-inflammatory food. That's why that was in there. Diet and systemic lupus erythematosus from supplementation intervention. So this was a neat systematic review. So, in the medical literature, you have kind of related ideas. You have systematic reviews where they say, look, we're gonna consider the totality in the medical literature of X, Y, and Z. And then you have a related idea of a meta-analysis where if you have enough trials with similar inclusion criteria and similar interventions and similar outcomes, then you can mathematically, statistically combine everything into like one overarching analysis. So this was a systematic review, but not a meta-analysis. And I put this up sort of for fun and also to see the way that these things are a little bit kind of constrained. So the project was done under the supervision of an expert librarian. I always feel better when I'm under the supervision of an expert librarian, especially when I'm at the library. And we searched using not me, I'm just reading this, guys. We searched using the term systemic lupus erythematosus, okay, great, combined with terms such as dietary supplement, diet intervention, nutrition treatment, vitamin D, vitamin E, curcumin, omega-3 fish oil, calorie restriction, and glycemic index. So you can see how, to some extent, they already knew what they were getting into. These guys were experts in this, and they already knew there was some literature on some of these ideas. So to an extent, the search is kind of constrained around that, but they put broad terms like nutrition and so on and so forth. And this is what it looks like when you do a systematic review. I've been involved in a few of these, not a ton of them, but a few of them. And they often look something like this. Like they searched 3 major databases, including PubMed and Cochrane and a couple other archives. And by the way, for anybody who doesn't know, if you want the best information from the medical literature, just go to PubMed. Like a bar and a medicine. PubMed. And and you can just do general searches, or you can do advanced searches, and you can put certain things in the title. So if you're looking for good quality medical information, I suggest either like go to a university-based site or a trusted organization site like Lupus Ontario, or go to the medical literature directly and see what's been published, because there's all kinds of things out there that are theories worth testing, but have not yet been tested, or have not been tested in a rigorous enough way to make it to the literature. So that's a little food for thought for y'all. And look at how these things go. It's like they start with like from Medline or PubMed and Embase, Cochrane. Like, wow, wow, they had 2,754 records. This is going to be like a long talk. And then they went, oops, okay, there's like duplicates and so on. And then they get down to 2,304. And then they actually, checked to see what was meaningful. And then they got down to 24 studies. And then, a bunch of them had poor data and a poor methodology. And then at the end of the day, they got 14 studies. Okay, so these are 14 studies, and I'm going to show you, like some of the results from these studies. Okay, vitamin D and SLE. I put this slide up just to highlight, like in the closing paragraph here. If you look at the amount, I'm not. And by the way, we have to give the usual disclosure. This is not medical advice. Talk to your health practitioner, your healthcare team before making changes to your health. And what I'm doing here is for information purposes only. I'm not recommending anything at all to anyone, except food for thought. So vitamin D is one of these things I can tell you in practice. Like we used to test every single person's vitamin D until the ministry started to charge for that to patients, and we still end up testing most of our patients. And like everybody who's going to be on Plaquenil, for instance, has to be SunSmart. And actually, we can make the argument that everybody should be wearing sunblock, and we're making everyone deficient. But I can tell you, it is all over the map how much vitamin D a person needs to be sufficient. Just today, we had a woman on only 1,000 international units a day, which is 25 micrograms of vitamin D3. And her numbers were spot on. In fact, her 125, her active form of vitamin D was a little bit like appropriately high on that. So, or other people, we have to give them like 10,000 units 3 times a week, or sometimes 5 times a week, or sometimes even more than that. In these studies, they went up to 1,250 micrograms a week, which is like 50,000 units. So some people might be familiar actually going out of production, but a drug called Osteofort, which was like vitamin D2 at 50,000 units a week. And our practice is to use vitamin D3. But anyways, just to give people a sense of this, like the trick with a lot of nutritional studies is like, if you're not targeting a level of something, then, you don't know. Like I just said, 1,000 might be like plenty for one person, and 1,000 units a day might have someone else with a vitamin D completely in their boots. And so here, I'm going to present these tables of the results of these studies. So, the main findings are in this column to the right here, which, long story short, these studies showed overall that when you give someone vitamin D, you can get their vitamin D level up. Okay, that's good news. Some of them did sort of surrogate immunologic biomarkers and found, for instance, in this study, reduction in the interferon gamma. And folks might be familiar with interferons and interferon alpha and interferons in lupus, and our newest biologic in lupus, Safnello, which blocks interferon alpha. So, one of the ways a person can consider the inflammatory effects in the blood is to look at a ratio here of interferon gamma to IL-4, and you can see how that improved, and it was statistically significant. And similar findings here in another study that looked at interferon alpha inducible genes. But in this group, they didn't actually find it. So they looked at a similar idea, but they actually didn't find any benefits there. And this is the second page, all about vitamin D. So again, significantly improved the level, but didn't improve disease activity. Whereas this study looked at CD4 positive IL-17 cells, and a ratio of T regulatory or sort of anti-inflammatory T cells to Th17, or you could say pathogenic T cells. And so that was improved in that parameter was improved in the vitamin D group, and these guys did show some improvement in disease activity by the SLEDAI that you guys may be familiar with as a disease metric, clinical disease metric that includes clinical findings and lab values in lupus, born out of Toronto, and Daphne Gladman and colleagues there. And then another study that really focused in on bone density and found that that vitamin D and calcium had positive impacts on bone density in lupus patients, and decrease the frequency of like mild to moderate bone loss or osteopenia from 40% to 16.7%. And you know, these are like small studies and so on, but so that's some information about vitamin D. I would say my take home on vitamin D is like, you know, if you have lupus and you're, especially if you're on Plaquenil, but just lupus itself, right? A person should be sun smart. We should all be sun smart. We should all be sun smart, and we should all, in my view, get our vitamin D checked. And we did a neat little study in our bone health patients and found it's probably better to be towards the mid to upper range of vitamin D range, which ranges like 75 to 250. We try to get all our patients up over 100 of 25 hydroxy vitamin D in the general case, and probably a little, you know, towards like solidly in the mid range is better. I'm not giving anybody like an exact answer on that, but you know, when you have something with such a range as 75 to 250, you know that there's probably a better sweet spot for the individual. Okay, the next bit here is on omega-3 fatty acids like EPA and DHA. So I put up a little slide on that. So this is eicosapentaenoic acid and docosahexaenoic acid. So these are long chain polyunsaturated omega-3 fatty acids. And this is actually what I did my master's in, related to. It was like a mouse model of related to diabetes and kind of in a way related to a lot of what we're going to talk about in a few minutes. And you know, the cell membrane, the cell is made of a lipid bilayer. So it's a really like this beautiful design, which has these phospholipids. So they have fatty acids, these little tail things here. So that the outside would be like, here's like, say, this would be outside the cell up here, and this would be inside the cell, the cytoplasm here. You can imagine this thing going around like a, you know, an oval or an egg or whatever, a cell. So this is just a cross section. So the way a cell membrane sets up is that the heads are hydrophilic, so they'll orient towards water, and the tails are hydrophobic, so they'll orient away from water. So it's like, it's a beautiful structure where just the relative affinity of this molecule, a phospholipid with its two fatty acid tails, really is critical in setting up the structure of every membrane of every cell in our body. And then the different tails are a function of dietary intake, and that's what I did in my master's, is fed different diets to rats and looked at the way that affected these fatty acid tails in their muscle. And what does that do? Well, you know, it changes membrane fluidity. So this is like this still picture, but the reality is like all the things on the surface of the cell are zipping around at like a mile a minute. And so you have channels that are embedded in the membrane, and you have signaling molecules, receptors that are embedded in the membrane. And these things are impacted, their function is impacted by the composition of these fatty acids in the membranes. And you know, very interestingly is you have an enzyme called phospholipase A2 that cleaves arachidonic acid from the membrane. So it's like now you're using a bit of the actual wall as a signaling molecule. So in biology, like structure and function are very, very often and most often like one thing. Like it's like, oh, it's like, let's just take a piece of wood from over here and throw that in the fireplace. That should keep us warm for a while. And so, that's what the cell is kind of like. It's using fatty acids in the membrane signal. And the reality is, when you have a high ratio of omega-3, something called a omega-3 index is one way of looking at it, or a high ratio of omega-3 to omega-6 in cell membranes, well, it sets up an anti-inflammatory signaling pathway in the cells as opposed to a pro-inflammatory one. So that's, a little background on omega-3 fatty acids. So these are things that, mainly we get from fish. You can get linoleic acid from plants, but you can't get EPA and DHA in significant quantities from plants, and we can't synthesize them. So interestingly, fish get them from algae. So for any vegans, there are some seriously like high-end algae-based products. I haven't actually seen them, but I've heard about them. So the reality is you can get omega-3. The omega-3 actually comes in the first place, not from fish, but from algae, and the fish concentrate it. Okay, so the reality is that omega-3 supplements here had some positive impact on lipids. Omega-3 will tend to bring down triglycerides. It sometimes bumps the LDL cholesterol up, which is not what you want, but it can definitely bring the triglycerides down. On this study, they saw improvements in the ESR, an inflammatory marker. In this study, they looked at vascular health. They found no significant differences in flow-mediated dilatation, inflammatory markers, and disease activity. In this study, omega-3 increased, so no significance in some cytokines. IL-6, which is a pro-inflammatory, we would say, and IL-10, which is an anti-inflammatory cytokine. Adiponectin, which we have another slide on upcoming, which is a quote unquote good adipokine, meaning a mediator that's derived from fat cells from adipocytes, and leptin, which is a quote unquote bad one. So they didn't see any changes there. Omega-3 takes increased serum cholesterol and LDL cholesterol. So, that's not the best. And then in this study, low-dose omega-3 supplement improved disease activity as measured by another index, the SLAM-R, and the BILAG. Also improved endothelial function. So this is like the lining function, the lining cells of our blood vessels, the endothelium. And we want nice, smooth flow in our blood vessels. Reduce oxidative stress. And in this last study, they saw improvements in plasma adiponectin, which I just mentioned, and reduced leptin. So like good, we would say, benefits of reducing cardiovascular risk and significant reduction in disease activity, interestingly. And, different amounts of these fatty acids, some of them gave up to 4.5 grams. There is interesting work in general that omega-3 reduces cardiovascular morbidity. Importantly, there is some association, maybe a 13% risk with high dose omega-3 of atrial fibrillation. So, nothing without risk. Even these omega-3s, Paracelsus is looking smirky as usual and going, yeah, I told you guys, you thought it was just this amazing thing, omega-3, and it's actually might be a poison to the wrong person at the wrong time, and so on. So nothing's perfect, and you do have to be careful with omega-3s in terms of anyone with a bleeding risk, anyone with high LDL, and anyone at risk for atrial fibrillation. So, there are some caveats thinking about omega-3. Okay, curcumin, which is like or turmeric, the active ingredient in turmeric is curcumin. And So one little study on that was like curcumin with or without vitamin D. So in this study, increased serum vitamin D, TGF beta, which is an anti-inflammatory cytokine, and decreased IL-6, which is a pro-inflammatory cytokine or signaling molecule, and improved disease activity in both groups. No different effect by curcumin supplements. SLEDAI score had a moderate positive correlation with serum IL-6, but not TGF beta. So curcumin is our most anti-inflammatory food, but nothing to write home about in this one little study of 39 patients so far. And now in this study, they looked at the composition. So both low GI, so glycemic index, which we'll get to again in a minute, and low-calorie diets were safe and well-tolerated. Significant weight loss occurred in both groups of participants who used low-dose corticosteroid. Low glycemic index diet lost 3.9 plus or minus 0.9 kilograms, and low-calorie diet lost 2.4. And so both groups lost weight from baseline. No significant difference in the effect of the two diets. No significant changes within or between groups in the disease activity, cardiovascular biomarkers, nor insulin sensitivity. Weight loss and diet intervention might contribute to improvement in fatigue. Okay. Now, so that's like up to the minute of 2022 of like specific interventions in SLE. So not a ton there in the medical literature so far about lupus per se. However, like I said, I'm going to back up and kind of back out for the rest of the talk here. And this is a really neat figure showing cardiovascular disease risk factors in SLE. And cardiovascular disease is our #1 killer in Canada and most of the Western world. And then look at all these other factors. And we tend to think about like active SLE as a risk factor, or even active rheumatoid as a risk factor, just like a traditional risk factor like diabetes or smoking. So look at these risk factors: smoking, high blood pressure, diabetes, lipid abnormalities or dyslipidemia, metabolic syndrome, which we're going to talk about, overweight and obesity, which is highly correlated, and a sedentary lifestyle, which is correlated, having a history of nephritis, having a high CRP inflammatory marker, being treated with glucocorticoids over 30 milligrams a day. And interestingly, some correlation with methotrexate, that might be a marker of more severe disease, or homocystinemia, antiphospholipid antibodies, inflammatory molecules. So in lupus, when we think about controlling lupus and doing beautifully with lupus, it's like, anybody who's seen Murray Urowitz talk has probably seen his sort of bimodal data from the U of T lupus cohort, where there's the problems with active lupus in the early on stage, and then there's problems with vascular disease and osteoporotic fractures and so on later down the road. So really in lupus, we can sort of really back this up and just think about vascular health, or really we just sort of back it like all the way up. And here's Sir William Osler from who grew up he was in Dundas growing up for 8 years. I was in Dundas growing up for 4 years, and it's where my mom and stepdad still live. So a little hometown hero for me, Sir William Osler, who's really the father of like the new era of modern medicine. So in the late 1800s and early 1900s, the good physician treats the disease. The great physician treats the patient who has the disease. And we could sort of like unpack that statement a few ways. One way is to say, okay, guys, like this isn't a disease, this is a human being. And so like back up, you're dealing with a person here, you're dealing with a family, you're dealing with a life, you're dealing with a context, you're dealing with hopes and dreams and so on. And, that's one way of thinking about it. But I would say, even a more fundamental way of thinking about it is to say that, diseases, like we're not treating diseases. We're treating people, and it really takes us to a shift in frame. Like for me, and this is not a plug, but just as an FYI, as a for instance, like where I've come in my journey in medicine over the last 25 years is another rheumatologist, Saeed Sheikh, and I have launched a venture called Precision Longevity, where we really like think about health instead of like from the outside in and wait for a disease to happen. Like we don't really have healthcare, we have disease care, because the person has to have a disease before there's something to treat. But of course, by the time a person has a disease, it's too late to prevent it. So, and our focus is shifted from a kind of inside out or bottom up approach to health and wellness that recognizes the gap between what's like normal, meaning, if you look at the average North American, and you might say they may or may not be healthy because they might tend to be pre-diabetic and carry extra weight. They might tend to be sedentary and have high blood pressure and high cholesterol and so on. So like what's normal and like what's optimal, and modern medicine in the general case doesn't necessarily always have that. Okay, and then this takes us way back in our big frame to our cave person days. And we're, as I say, we're all cave people who've been teleported to a foreign land, and that's why they have the like the plexiglass, the glass, whatever it is, over the buffet at the Mandarin, because we all kind of tend to drool a bit. And so we can draw everything back to the cave person who's toughing it back to the cave, trying to avoid tiger attack, so they can enjoy their kill. And a lot of our physiology just all, drills back to that, right? Our fight or flight response, fight, flight, freeze, and our cortisol biology, and we tend to live day to day in the Western world as if we're under constant tiger attack. And so all of the way the immune system and the inflammatory system and the sympathetic nervous system, fight or flight or freeze, wires together, kind of takes us to the inflammatory and the anti-inflammatory diet. And prednisone, which gets you through the night and gets you past an acute inflammation, is not good in the long run, as we just saw in an earlier slide. So, and what does that caveman want when he or she is huffing it back to the cave? It's like anybody who's been on prednisone, including myself, knows. What do? We crave sweets. We crave high energy dense foods and carbohydrates. So, we don't have a ton of time, but just I'm going to turn you guys onto the idea of glycemic index, and the idea that there are low and moderate high glycemic index foods. And of course, it's about quantity and dosing. And so there are some frames of reference of things that are high, medium, and low. So we're not surprised to see white rice, white bread, baked potato, watermelon in the high category, and chickpeas, bean sprouts, spaghetti, carrots in the low category. And so what does that mean? It means, like, to what extent does a person's blood pressure spike up after a meal? And interestingly, in a very high glycemic food, this is like, the crash, the sort of carb crash. And really, like, so much of the anti-inflammatory diet and inflammation drills back insulin, which has multiple effects, metabolic effects. Like, in a line, we'd say, what does it do? It gets glucose into cells. It tells the liver and the muscle to stop releasing glucose because lots of it's coming in. And this would be a nice kind of homeostatic slide on insulin, meaning what's happening in the healthy, when things are functioning well. But what happens when things are not functioning well? And this is, look over here on the bottom right here, the new model of diabetes. So, hyperinsulinemia precedes insulin resistance, precedes beta cell exhaustion. These are the beta cells in the pancreas that make insulin, and that lands at type 2 diabetes. So if you look at this slide, you've got insulin in red, insulin in green, insulin resistance in red, and glucose in blue. So what is this? You imagine like a 10-year span here. And so what will happen, it's like inflation, particularly as a person gains weight, especially if they have a family history of diabetes, especially if they eat a lot of, high glycemic index food, but particularly if they're carrying extra weight, what will happen? For years, likely to be able to maintain their glucose level in check, but that's at the cost of insulin resistance. What does that mean? It's like inflation. It means In order for a given level of glucose, it takes more insulin to do that. And then what happens over time, the pancreas gets tired. And it's not till the pancreas is like, on its way out the door that the glucose actually starts to raise. So, a lot of your family doctors and maybe your specialists would probably think that we're a little crazy over here at the Waterside Clinic because we measure insulin levels, fasting insulin levels. And when I started medical school 25 years ago, I said, well, if hyperinsulinemia precedes diabetes by maybe a decade or more, why do we wait for the glucose to go off? Why aren't we measuring the fasting insulin? And it was sort of like, I don't know what to tell you, Derek. And it's still that way. People don't tend to check it, and we check it in all of our inflammatory patients because of the major connection. And so, this is the metabolic syndrome or the insulin resistance syndrome, which correlates with all of these interrelated vascular risk factors: abdominal obesity, high blood pressure, high blood sugar, high triglycerides, disrupted hormonal axis, central obesity, coronary artery disease, physical inactivity, type 2 diabetes, and aging itself. The metabolic syndrome accelerates aging. And by the way, not listed on this is like dementia and cancer, which you could also put on here, and increased risk of infections. So a big tie-in with this and the anti-inflammatory diet is, a modulation of the gut microbiome. So, there are 10 or 100 times more microbial cells in us than there are our own cells in us. And so anti-inflammatory diets have major positive impact on the microbiome. And if you look at people who eat, a pro-inflammatory diet, their microbiome is contracted and it's aberrant, and it has a pro-inflammatory makeup. I mentioned this idea of adipokines, okay? And so adipokines are these inflammatory mediators that are released from adipocytes. And adipose tissue is all lined and infiltrated with inflammatory cells. And by the way, atherosclerosis, the cause of heart attack and stroke itself is entirely, at the heart of it, it's an inflammatory disease. So all this stuff really ties together. Here's Peter Attia, who's a Canadian or an expat, I guess we could say, who now lives in the States and who's like a longevity expert. And, this is probably one of the biggest take-home things. I'm going to show you a few more slides to wrap up. What Peter Attia, I heard say recently that really struck me, and I think it's like a huge take-home, is he said, if a person is focusing on the types of food more so than the amounts of food, and they're carrying extra weight and they don't have the caloric level right, it's like majoring in the minor and minoring in the major. And which takes me to what my middle son Jacob said to me as he saw me preparing for this talk. He's like, well, how come you're going to speak to them, Daddy? Aren't you sort of fat? And so I had to have a little chat about that, and he was sort of right. What is it like? Why do we have all these junk foods around? Why is all this stuff that's bad for us, so plentiful? And well, it's like we're all these cave people, and what's happened? It's here's a great book title that really encapsulates it, and a book that encapsulates this idea: the hacking of the American mind, the science behind the corporate takeover of our bodies and brains. So guess what we lacked? What we lacked in cave people days, fat and sugar and salt, is now abundant in every corner store. And here's the Mediterranean diet pyramid. And I'm sure most of us could sort of draw this, and we would know that yes, meats and sweets are things that we should limit. Poultry, eggs, cheese, and yogurt are things that we should limit. And the things we should, and alcohol is something we should limit in moderation. They say there, red wine in moderation. They say drink lots of water. We can't overemphasize that. Here's all the stuff at the core of the Mediterranean diet: fruits, vegetables, grains, olive oil, beans, nuts, legumes, seeds, herbs and spices, fish and seafood. And so, and I don't have to tell you what a Western diet tends to look like. And it's kind of like the Mediterranean diet upside down. and you know, we can all pick out which picture looks healthy and which picture doesn't. And you know, the science is real in all of this. So this is like where this idea of the anti-inflammatory diet comes from. I tried to find like a better table that was listed in like descending order of anti-inflammatory quality. But for instance, in this table, if we find here the turmeric up here, you know, 0.774. So in this table, you know, these high numbers are anti-inflammatory scores. You know, carbohydrates would be more inflammatory. Omega-3 is anti-inflammatory. Omega-6 is inflammatory. So, you know, I'll let you guys explore that, but you know, this is like the actual paper where they looked at all these foods and a huge, massive review of the literature and the impacts of these chemicals on inflammation. You know, the naturopaths are right. We all have a bit of leaky gut, and you know, to have an anti-inflammatory diet, which by the way includes high fiber, psyllium fiber, pure psyllium fiber, something we tend to recommend for everybody who can tolerate it. You know, they have nice tight cell connections in their gut, and a lack of toxic chemicals getting into the system. Just a word to say, you know, we've got this whole set of things called polyphenols and a subset of that called flavonoids. And, you know, I don't have to tell you, you can tell these foods are good for you, right? We all know that fruits and vegetables are good for you. It is like really, really a true story. I had a bit about flavonoids and like massive, like positive effects on inflammation and cancer risk and antioxidant and vascular health and so on from flavonoids. And by the way, here's a review of milk and dairy products, which actually, you know, I think for some people milk is pro-inflammatory, but as a whole, in the studies available, it's not been found to be a pro-inflammatory food, according to a recent systematic review. Okay, guys, I'm a little over time. It is 7:48, but not too bad compared to how late I usually am. These are my three sons about 10 years ago or so. Well, yeah, eight years ago, maybe, my three sons there. Kyle, the youngest, Jacob, who was commenting on my body size, and Noah, who's now 17 and 6'3" and 191 pounds. Okay, guys, that's my anti-inflammatory diet talk. It is a bit of a whirlwind of a talk, but anyways, food for thought for you, and we've got hopefully some questions, Alex.
Absolutely. That was very informative. So thank you very much for that. I will just go over these, I guess, in order. So number one, will OHIP allow me to see if I already go to a lupus clinic in person or phone call twice a year? My lupus clinic is a 6-hour drive away. Aurelia is 1.5 hours away.
Yeah, so the answer is, I mean, we have patients, you know, we're part of the McMaster Lupus Clinic, and actually the vision here is to make this clinic here in Aurelia, the Waterside Clinic, a satellite of the McMaster Lupus Clinic, where I also work. So yeah, and we have patients who we share with the folks downtown at Toronto Western, and so yeah, that's definitely possible to have like shared care of in lupus. Yeah, we do that like often.
Okay. I'm not exactly sure what part of the presentation this was speaking to, but is this relevant to all types of inflammation more than just those suffering from lupus?
Right. So that's why I kind of set up the talk the way I did when I, you know, like, because there's not a ton of specific stuff in lupus, right? But the beautiful stuff about all of this is it applies across the board, almost, you know, not without exception, but yeah, you know, like atherosclerosis is an inflammatory disease, and really all of these things tie together. And the like, it's not like there's certain studies that show anti-inflammatory diet is, yeah, unfortunately good for this, but like bad for these other things. Like an anti-inflammatory diet, which by the way, I didn't even put the data up, has shown, you know, benefits in all-cause mortality, and you know, from at least retrospective data. So yeah, it's that's why I kind of set the talk up like this, is I sort of zoomed in on lupus and then zoomed back to say, really, like I wouldn't think about treating lupus with an anti-inflammatory. I think about treating all of us with an anti-inflammatory diet, just us human beings here.
Right. I mean, it definitely makes sense to me when you say it like that. Number three, where we go here? What is your opinion on nutrition IVs like the Myers cocktail and glutathione?
Okay, interesting. And again, like this is just, this is just, not medical advice. I'm not familiar with I've heard about Myers cocktail. Do I think there might be some things that are going to be ultimately given best as IV? Yes. Am I aware of any nutritional things that at this point in time, other than maybe iron in the person who cannot tolerate the oral iron formulations, that really should be given IV? Am I aware of that? Let's see. Sometimes we'll replete magnesium like that. There are probably some good examples, and if those folks were here, they might explain to me why we need IV of certain nutrients. But I am, I can't think of any off the top of my head, but it's not something I've super explored and IV nutrition. I'm sure the answer is the devil's in the details, right? If Paracelsus were here, he'd say, yeah, sometimes it's important, and here's where. But I couldn't give you a sort of blanket answer to that. The idea of glutathione, again, this is not advice, but people over 40, our glutathione levels really tend to tank, and reduced glutathione is a major antioxidant system in the liver and elsewhere. If you want to, again, if a person, and not medical advice, but if a person takes, rather than taking glutathione, I'd say this is an important principle. If you can take the building block of something and let your body's enzymatic function decide how much of it needs, that tends to be a better approach than giving the finished product, which your body may or may not be able to deal with. So the way to support glutathione is probably with N-acetylcysteine. And you can look at some of the literature around this, and it's sort of up and coming. Like most of the trials in N-acetylcysteine, like probably most dietary trials, you have to give years and years before you're going to get the endpoints you want. But N-acetylcysteine is a supportive nutrient that can optimize glutathione and antioxidant function. By the way, guys, too much antioxidant is a bad thing. It's been shown that antioxidant supplementation after exercise actually, shoots the exerciser in the foot a little bit, because you need a bit of an oxidant environment to trigger healing. So there's a sweet spot, just like Paracelsus would tell us, for everything, including antioxidants, for sure. So a person has to be careful.
Okay, so on that topic of too much, we have a question here that says, do persons of color generally need to take double the recommended amount of vitamin D, and what's the danger of having too much?
That's a great question. And I can't quote you any evidence on that. We just take a very customized approach to vitamin D. Like all of our bone health patients, we track their vitamin D. All of our immune patients, we track their vitamin D, and we optimize their vitamin D. So I can tell you it is actually all over the map. In terms of like I started out with. So I don't have some rule to say, people of color need twice as much or anything like that. I would just say that we all need to be sun smart. We should all be wearing sunblock. The main risk factors for skin cancer are having skin and going in the sun, like all of us. So I really recommend sunblock and supplemental vitamin D3, and targeting a level to at least 100. Talk to your health practitioner if they think I'm crazy for suggesting to measure vitamin D. And the harms of getting too much vitamin D is, well, it's hypervitaminosis D. It's a fat soluble vitamin. In the worst case, causes liver toxicity, but in milder cases causes like hypercalcemia, like for instance the disorder sarcoidosis that associates with high active vitamin D levels, causes high calcium, which causes all kinds of problems.
And that can be calcium anywhere, correct? In the kidneys.
Right, exactly, Alex. So you get, a person could be at risk of renal stones, could be at risk of vascular calcification,
right,
with too much calcium, and among other problems.
Okay, so another question we have here. I'd love to know how much omega-3, 6, 9, and is it curcumin? You
Yeah,
try and share info. Um, yeah, how much omega-3, 6, and 9
yeah.
is
Okay, so again, talk to your health practitioner. Like I said, omega-3s are not without risk. A person can have measured their omega-3 index. It's something we're doing in our in our holistic venture. And so really targeting an omega-3 index is probably the way to think about it. Um, people in North America have an omega-3 index of 4, and people in Japan have an omega-3 index of 8, as a for instance. And we don't quite know the sweet spot. Somewhere between 8 and 12 is the sweet spot of the omega-3 index. So most of these nutritional things should be thought of not as like a dose, but for anything where we can actually get a level, like to think about titrating a level. But that said, the omega-3 doses are in the range of 2, 3. One of the omega-3 studies was 4.5 grams a day of omega-3. A person wants to think about omega-3 from small fish. Large fish up the food chain can have heavy metal toxicity. And then curcumin, you look at the different studies, like that's a whole other topic. You can look at curcumin, some positive information in osteoarthritis. Um, Curcumin is the active ingredient in turmeric. A lot of the turmeric studies, you can look them up. Like turmeric studies will look at 500 milligrams twice a day, some dose like that. Turmeric also not without risk. Every food is a poison, Paracelsus. And so, there have been cases of liver toxicity and bleeding risk with turmeric. So a person has to be careful. There have also been, hey, a huge thing in the nutraceutical industry is the lack of regulation and the charlatanism that abounds. Recently, there were cases of a company out of India who was putting lead, imagine, in their turmeric supplements to make them more vibrant orange. So it's like it is an absolute buyer beware story, and that's something else we're really trying to focus on is like finding the best third party certified supplements, and that's like a big work in progress.
right. Okay. I have a bit of a long one here. Thoughts about the relationship between lupus and mast cell disorders. Do the patients with restrictive diets due to anaphylaxis impact or does it make them worse? And do you have names of specialists who can manage both disorders in Ontario?
Yeah, I'm again, sorry, it's like a little like horn tooting, I guess, because you asked a question. I'm the only Canadian who's trained in rheumatology and clinical immunology and allergy, like certified in both of those specialties. So and there's one other guy. There's one other guy in the GTA, but he doesn't do rheum. He does pretty much he does allergy. Um, so I'm the only one that I know who is certified in that. I will say that some colleagues at McMaster that I trained with, like Judah Denberg and Susan Wasserman, and Paul Keith and Mike Sear, who are like my great mentors. A lot of them deal with autoimmunity and mast cell disorders. Other than them and me, I don't know of anyone else in Ontario. But yeah, so mast cell activation syndrome and the mast cell in all of this is a whole other talk that I'd be happy to have a chance to talk about someday. But listen, anyone interested in mast cell biology, look at mastcellmaster.com. Theo Herrides out of Florida, brilliant guy. I've had the great opportunity to talk to a couple times. Like 400 plus papers all about mast cells. Are mast cells important in lupus and in rheumatoid and on and on and on? Absolutely. Um, yeah, so it's like a whole other topic on mast cells, but mast cell activation syndrome, and mast cell biology and allergy. Like lupus actually brings together a lot of things because you can have angioedema and lupus sometimes, and urticaria and lupus sometimes, and so on. So tons and tons of connections. Everything's connected.
Mhm. Are you familiar with the Goodbye Lupus Protocol by Dr. Brooke Goldner?
The Goodbye Lupus.
Goodbye
Goodbye
protocol, where she
Lupus.
advocates for
I'm not familiar with the Goodbye. I'll look that up. That's an interesting question. The Goodbye Lupus. Is there any more information about it there, Alex?
Well, she advocates for I guess smoothies and a sort of vegan diet.
Like, listen, all these things, like you look at all these diets, you look at the autoimmune protocol, you look at this, what's the person's name, Alex? I'm gonna write
Dr. Brooke Goldner.
Brooke Goldner.
Yeah.
Um, I'm not familiar with that one, but just from what you just said, hey, I love smoothies because you can just put anything in it. It's like you can drink broccoli, you can drink saffron, you can drink curcumin. Um, but obviously you're treating like foods like drugs, and you got to be careful. And with the supplement side of it, right? Just like a drug, you got to judge everything on its own merits and treat it just like a drug. But all these things, vegan diet, um, even the caveman diet and the lion diet and the autoimmune protocol, even the Atkins diet. Like, what do all these things? They all share in common a low glycemic index. A vegan diet is increasingly being shown to have positive effects on the epigenome and longevity. I think we're going to see that, hey, Einstein said vegetarianism is the only sound way forwards for humanity. I think there are many reasons that a plant-based diet is absolutely an anti-inflammatory diet, and so I'll check out the diet. I have no specific comment on it, but you'll see all these. The carnivore and the lion diet are a little out there for me, like, but I think an anti-inflammatory Mediterranean, vegan or vegetarian or pescatarian diet is like, there's so many different diets, but the Mediterranean diet, and by the way, I didn't mention olive oil, which is like such a central part of the Mediterranean diet, to use olive oil as the main source of fat. Like, I suspect that doctor's protocol, Goodbye Lupus, I suspect it's based on all the same kind of principles we're talking about.
I'm just reading the chat here, and someone commented that she is an author, specifically helps with lupus, and apparently healed herself through her own protocol.
And
Just to
and
give
we've
you some
seen
back.
and we've seen so many people who've done so well with a clean diet and an anti-inflammatory Mediterranean diet and fitness program and mindfulness, meditation and sleep and so on. And we have kind of like our foundations of health and wellness that we give everybody. And I can tell you, like we have story upon story of people said, wow, I didn't realize like how much better I would feel when I did X, Y, and Z, like on and on and on, for sure, for sure.
100%. Okay. What markers do you see for early lupus detection? How do we prevent it from getting to a point where you end up in organ damage?
That's a great question. Like, some of you have probably seen the like New England Journal of Medicine paper from 2003, where they looked at US military officers who got lupus, and then they could look back in time and look at their blood samples from years and even a decade before, and they saw the way that autoantibodies emerge. So, and you folks probably know, like, in the new criteria, like, there's really, you never say never, you never say always in medicine, except in this sentence, but ANA negative lupus is not a thing, with the rarest exception that we could consider together. But really, ANA is a sensitive marker, and then you've got the more specific markers like Smith and anti-DNA. But your question in the invitation is a beautiful one. Like, how do we um, reveal relevant preclinical autoimmunity, and how do we mitigate that? And that's a beautiful question. It's very hard to do like randomized controlled trials in people at risk, because only a percentage of those are going to go on to get the disease, and you need gigantic long range trials. But your question is beautifully placed, and it is absolutely like my interest and angle is to say, like, how do we pick up the subtlest forms of things. And, you know, how do we keep an open mind about things? Because, you know, I don't know. I think I probably diagnosed way more undifferentiated connective tissue disease than a lot of colleagues because, you know, you know, there's always a tension between sensitivity and specificity. Like if you want it to be a slam dunk, everyone's going to agree. Well, you're going to miss a whole bunch of people in that. So we try to take a, you know, it takes a healthcare system that is tuned in, you know, even to get the early cases who are just say marked by fatigue and some arthralgia, you know, to go to the questioner's vantage of backing it right up to preclinical disease, it takes a different system of medicine. And that's like precision longevity. Like that's what we're trying to do because, like I said, when you wait for a disease to happen, it's obviously too late to prevent it. And we can see there's so much room for prevention in all of this. So I don't have a good answer for that question other than to say I really love the question and it's a beautiful vision of the future.
Great question. Yeah. Another question here is what markers do you see, or no, sorry, we just went over that one. Is turmeric recommended for people on blood thinners?
Right. So, you know, like, first of all, I'm not recommending you guys do anything except, you know, think about it and make your own informed choices and talk to your health care practitioners. But as a rule, you know, turmeric has some antiplatelet and maybe even anticoagulant effects, and definitely can impact a bleeding risk. And in it, as a general rule, a person would say, you know, be to the, you know, like to avoid or have to be very cautious and have a thoughtful discussion about that with their practitioner. You know, think of turmeric as a drug, right? Think of it just like a drug and say, okay, I'm on a blood thinner. Can I take turmeric? Just think, it's like, can I take ibuprofen? Like, no, probably shouldn't. And should I take turmeric? Probably shouldn't. Should I avoid it in my diet? Like, you know, there's a sweet spot for all these things. And it's like, oh, do I have to stop eating all this stuff? Well, you know, I think to take it in a nutraceutical dose, like to start taking it as a supplement in a capsule, you got to talk to a health practitioner and weigh that balance. But your question reveals the thoughtful point, which is that you know, turmeric is blood thinners are at least a relative contraindication of turmeric.
Okay. Do doctors suggest supplements to counteract the negative effects of meds? For example, the use of calcium, omegas, probiotics, vitamin C and E.
Well, some doctors do, you know, like a great way to think about it for me is like, you know, Western medicine is all about like adding things on. It's like, oh, what are we going to give you? How are we going to treat you? Oh, here's your pills. But, you know, the first step is really like cleaning house and saying, okay, before it's kind of like cleaning your closet, right? You kind of take everything out to clean it. You got to take everything out and decide what you're going to put back in. And I would advise for that we all should think like that about our lifestyle, like overall. You know, I think probably a lot of doctors advise some calcium and vitamin D for bone health, you know, and it would probably wane after that, you know, like I'm a little on the more is more side, like, you know, I think like supplemental vitamin D, a multivitamin with appropriate, you know, iron, meaning menstruating women need it, and most other people don't need iron in their multivitamin. Like psyllium fiber, you know, collagen, hyaluronic acid. You know, these are like some of the things that I, you know, show a lot of promise. But you got to be careful. You know, you got to be careful, and you know, like I think treat everything like a drug. It's like the opening slides. You know, treat it all like drugs. Everything that's good for you is potentially bad for you. And yeah, what do most doctors do? I'm not too sure, but you know, I don't know. I think it's still pretty steeped in. I think preventive medicine is getting a little worse. It's going to get worse before it gets better. That's what my take on what's going on in Ontario right now. But I've got a kind of like my own biased optic on it all.
No, I hear you. I hear you. I have another question here. I have lupus. I always have difficulty saying this, but I have lupus Sjogren's and
Sjogren's.
arterial Sjogren's.
If
Um,
anybody wants to know how to say Sjogren's, it's like a dental ad. Sjogren's. You know, it's what the dentist wants. They want to Sjogren's. Sjogren's. There you go.
so Sjogren's and fibrillation.
Yes.
That one's a tough one too. Did you say omega-3 is harmful?
I said that
And what about milk?
omega-3. Sorry.
And what about milk products as well for someone with lupus,
No problem.
Sjogren's?
Right. Right. So yes, I did say that omega-3 can have some impact on atrial fibrillation. It's a good question. Does it change the outcome in people with established atrial fibrillation? At least theoretically, it could make it worse or make it more difficult to control. So, you know, that one's like, no, hey, guess what? It's like all of our cell membranes are made of fatty acids. So it's not, you know, the answer isn't like a dichotomized yes or no. It's like, should people with lupus and Sjogren's and atrial fibrillation eat fish? Like, yeah, probably. Right. So,
Yeah.
but you just have to be careful with the dose and mega dosing it. And it could pose a risk to atrial fibrillation. Yes, it could. And dairy products, you know, like the last paper I brought up was about dairy not seeming to have any actually pro-inflammatory effects. I think that's variable. I can tell you, like doing allergy, there's a ton of people who feel way better when they stop drinking milk. I personally know that feeling, the way that milk can make you kind of congested. You do really wonder about this habit of drinking the milk that was intended for the animal of to the baby of some other kind of animal. And you know, but we can also say that, you know, culturally, many cultures have been doing that for 10,000 years. So, and by the way, milk is a huge important source of protein and calcium, and it's supplemented with vitamin D. So if a person, you know, like, so there are tons of benefits to milk too. So, you know, pulling milk out of the diet is something a person has to be real careful with too. And by the way, you know, and then you get into the whole topic of hormones and antibiotics and, you know, are they you know, is it organic milk or not, and so on and so forth. And I know a whole other topic there on milk for sure.
Are there resources or coaching that you recommend that can assist with adapting an anti-inflammatory diet or with losing weight post-prednisone use?
Yeah, I would say, you know, you want a registered dietitian, you know, and that doesn't mean you need somebody yell at you 3 times a week to tell you what to eat and not eat. And same, you know, I think people should we should all have a personal trainer or physio. Again, not to pay somebody to yell at you 3 times a week, but to like set you up with a program, right? You really, in my view, you want like a registered dietitian and someone within the personal trainer who understands your health limitations, as for all of us. And you want those two people to be in communication for each other with each other. And you want a program, and you want it to be, you know, you want to say, okay, well, how many pounds am I looking to lose, or how many inches here, or what is my goal? I'm trying to fit, you know, what are my benchmark goals so that I can recalibrate as we go. So obviously there's a zillion apps out there, right? But you know, I'm a big fan of like having professionals on board, acknowledging the costs of all of that and so on.
I have a few more here. What would be the best holistic way to keep yourself in remission from lupus?
Yeah, you know, hey guys, you know, like, you know, for anybody who hasn't checked it out, if you can still watch it, you know, like the Blue Zone series is a great series because what does it do? It looks at like, you know, 6 different traditions around the world. I think it's 6. And you know, and looking at the commonalities, what do these people do? It's like it's everything we're talking about. You know, they eat like, and there's also a guy who wrote a book and went all around the world to like all as many cultures as he could. And I forget his name, and I forget the book, but it's you know, the take home was like eat real food, mainly plants, not too much, you know. And you look at the blue zones, you know, what do? It's like, you know, they they have good sleep, they have relatively low stress, they have a meaningful role in a community, They live like a traditional life. They grow their own food. They get lots of exercise. You know, they all happen to drink a little bit of alcohol, but check out the Canadian low risk drinking guidelines, which basically say forget about it. And yeah, all of that stuff, right? It's kind of like I kind of have, a graphic that's like the autonomic nervous system, the autonomic nervous system, the inflammatory system, the metabolism and the microbiome, all those things we're talking about today, right? And how do you optimize your autonomic nervous system? It's sleep, meditation, mindfulness, psychotherapy, avoiding vexatious people, engaging in true activities, staying off screens, which we're about to do shortly, and all that kind of good, healthy stuff. I would say it's all, all the great thing about all the holistic stuff is pretty much all the arrows point in the right direction. It's not like, oh, smoking happens to be great for these 17 things and French fries are good for these 5 things, but terrible for it's like everything points in the same direction. So yeah, I'd really think about, it's like the foundations. It's emotional health, emotional, spiritual, intellectual, diet, fitness, purpose, family, community, all this kind of good granola stuff, guys.
Mm-hmm. Mm-hmm. Yeah. Speaking of no screens. So I believe you've kind of already answered this, but we have another question. Would adapting an anti-inflammatory diet help if you have lupus nephritis as your only manifestation?
Yeah, I mean, that's a great question, right? Like, so what's the evidence, right? And this is where, the evidence purists would say, listen, I'm not going to talk about, anti-inflammatory diet in my patient with lupus nephritis until I see a meta-analysis of 14 clinical trials and And you say, okay, but can we just sort of back that up? And what do we know? Like, I show that cardiovascular risk. Nephritis itself is a risk for cardiovascular disease. Nephritis itself is a kind of a vasculopathy. Do I have any reason to suspect that all of these good principles mightn't be good for lupus nephritis? No, I don't. But do we have a set of evidence that really speaks to it and underpins that? No, we don't. So it's like an open question, but that's why I back the talk up to just the general case. We're going to wrap up with one last question. Okay,
Yep.
Alex, what is our last question?
Our last question is, could genetic testing be a possible addition to lupus labs? In better understanding our actual genetic makeup, perhaps we could better manage our individual disease? Question mark.
Yeah, so you're really speaking to precision medicine and targeted therapies, and you're speaking to my you're singing on my songbook. It's called like polyomic medicine, right? It's like this is what we're doing at Precision Longevity is flipping, we're inverting things instead of saying, well, I'm just going to collect a few clues and then I'm going to take that to the DA and see if we can go to trial over this. It's like, no, I'm going to actually learn as much as possible. Oh, by the way, 23andMe is like going bankrupt. And we work with a company called Nebula, where we get whole genome, like in our precision longevity space, but which is very much like a preventive angle. So would genetics, it's like you don't know what you don't know. So you don't know what a genome reveals until you get it. You don't know if a person carries, ApoE4 that puts them at risk for Alzheimer's, or certain genes that associate with well, it's really endless, right? So the answer to the question is genetic information helpful? Yes. Are we using it in clinic on a routine basis in lupus clinic? No. Does it inform certain treatments? Like we go, oh, here's your genes, therefore this drug. A little bit of that, a little bit of that is there, like pharmacogenomics, but it's like the earliest days in all of this, and so as the ministry is like constraining out of necessity, constraining spending and constraining the tests available. The reality is like there's an ever expanding set of information to consider, like our epigenome and our genome and our proteome and our metabolome and our microbiome. And so, all of this stuff ultimately is relevant. But what we lack, and this is something that, is one of the big challenges is the information systems to deal with all of it. So your question is a beautiful question to finish on. Do I think genetics are going to be important in the treatment of lupus? Yes. Is it something that's a standard in clinic so far in lupus clinic? No, but do I think it's ultimately going to be relevant? And 100%, right? It's like it's the answer to that question, like, has to be yes.
So in short, the future of lupus research looks bright.
Yeah, in short, the future of lupus research looks very bright. And I think that, well, anyways, I wanted to invite like a holistic approach with this talk tonight. Because you can kind of hear it in the words. You kind of hear it in the words like medical doctor, MD, medical doctor, and medical school, and modern medicine, and family medicine, and internal medicine. And this healthcare system that we have is all kind of like, it's like so rooted in medicine. And I would just invite that we should just expand, the set of things that we consider medicine to be, everything that we could imagine. It comes back to Hippocrates and Paracelsus. And so, yeah, lots of, and you can see all the overlap between all of these ideas, like the microbiome and metabolic risk and diabetes and inflammation. And, let me just say this, guys, like all of this stuff, all of this kind of anti-inflammatory diet stuff, what does it do? It drops chronic inflammation and it improves immune function. And what happens when you do that? It means you get over infections more quickly, and actually you get less of them in the first place. And we all know that, infection can trigger lupus or trigger a flare of lupus. And the more quickly and succinctly and profoundly we, annihilate infection, the better off we are. So, yeah. On and on and on, everyone. Thank you so much for your attention this evening.
Yeah, and thank you for the very informative presentation. I'm sure I'm not speaking for myself when I say I'm very appreciative, but I see the comments. A lot of people are saying it was very helpful. Thank you. Every piece of info adds to our own tool belt. Exactly. And also thanks everyone for attending and just being so interactive and asking all these great questions. Thank you.